Go. There we go. Hold on. There it is. There we go. Doctor Joshua Schiffer, everybody. He should be here in a few seconds, but I hope you enjoyed that. There he is, everybody.
All right.
The good doctor. Cheers to you. This is not White Claw. I hope you know that.
Yeah. I feel like my work is done. You more or less answered the questions, and
Yeah.
a
lot of I have a master's degree, so it's all this stuff is pretty easy.
Yeah.
It's pretty simple to figure out. So I don't know. Seems like you guys are trying real hard, but of course I'll ask you the question that's on everyone's mind. What room in your house are you? And are those earrings hanging off your ears, or is that a chandelier?
It's a chandelier.
Okay.
Yeah.
That's great. Or is Fred Hutch like really well designed? But you're in your home.
I'm in my home. Yeah.
Okay. How much time do you actually go into the office for a week?
So I'm working in the hospital for these couple of weeks. So I go to UW Medical Center every afternoon to see patients. And I actually haven't been to my office at the Hutch in a couple of weeks. Really because of the West Seattle Bridge situation. There's a lot of dead time getting anywhere. So if I can avoid driving, I do.
So those of you watching this, there in Seattle, there's regular Seattle. I guess there's North Seattle, South Seattle. But there's a place called West Seattle, which is an entirely different neighborhood that's across the Duwamish River. And there's a massive bridge. And about 2.5 weeks ago, they discovered it was terribly unsafe. It's a huge bridge. You should look it up. And they have shut it down. And it's going to be, 2.5 years before they get a new bridge up?
Right. And there's a bridge under the big bridge, which is smaller. And eventually they might close that bridge for fear that the upper bridge might collapse under the lower bridge.
Can you imagine the moment that they discovered the bridge was going to fall? They're like, guys, we got. Oh, man. Seattle, for as rich as Seattle is, between the Alaskan Way Viaduct and the West Seattle Bridge and the floating bridge, our bridge luck has been pretty terrible.
Yeah. I mean, it certainly could have been worse. I don't get the sense that this would have done well in an earthquake.
No. So thank God they shut it down. So let's get to it. Let's see. I'm going to get right into my notes, and we're going to start talking about the virus and what's had the pandemic. And here's the first one. Do you think Carol Baskin killed her husband? Oh, hold on. Those are my Tiger King notes. Excuse me. No. So it's been 2 weeks since we spoke, and I feel like the news is changing by the hour. So with this being a pretty vague question, what's changed in the last 2 weeks?
So I think from the standpoint of epidemiology, and what I mean by that is that the extent of the disease in the community, there's good news, but also cautious news. That really it's very clear that flattening the curve has worked in our state, and I think most states in the country, and really globally, which is fantastic. And the number of cases is leveling off, and we can clearly feel that in the hospitals. The hospitals locally are not overwhelmed. In fact, they're less busy than usual because people seeking routine care are not in the hospital as frequently. So that's really, that's great. And it really shows, I heard a quote from a woman from Wuhan that I thought was really great, that social distancing is nothing more than a scientific method and I really feel like this validates the method and that we did the only thing we could do. On a more sobering note, I follow the mathematical modelers who look at the epidemic potential, and despite the fact that this has happened, it's still clear that in many states, and I'm just talking about the first wave here, where we might not even be through half of the cases, and we might not even be through half of the deaths, which is really, just hard to think about. But it's a different thing because the downslope of the curve is particularly with a flatten the curve approach is much slower than the upslope. And so it's not as if we're not seeing cases. We're still seeing new infections. We're still seeing people succumb to the virus, but it's at a slower pace and it will be extended. But there's still a lot of, unfortunately, people are going to suffer from this disease. And that I think is very clear from the projections. There's a lot of uncertainty, and that uncertainty grows as you get further away from where we are. And so it's a mixed message, and across the globe, it's similar. There are many of the countries that I really worried about, particularly in sub-Saharan Africa, India, heavily populated countries in Southeast Asia, haven't exploded yet, which is really great to see.
Why do you think that is?
Yeah, I'm not totally sure. There is speculation about the climate playing some role, and that the reproductive number of the virus might be lower in some of these countries because
the climate's a lot warmer.
Yeah, because it's warmer and perhaps more humid. But that's not, I don't think a scientific fact by any means. And the other possibility is that the countries got the message in time, because I think we talked about this last time, but with exponential growth, there is this period of time where you're under the radar, it's slowly growing, but it's doubling every 3 days or every 4 days. And so, if you intervene when the number of cases is going from 200 to 400, that feels a lot different than when you intervene when it's going from 20,000 to 40,000 over the course of 3 days.
Right.
And so it's possible that these countries were just seeded a bit later and that they managed to intervene on time. But I don't think the story's fully told yet.
Right. But so when you say, okay, so we flatten the curve, but we still might be, there's still possibly many more deaths to come and many more people getting infected to come. It's just that as it's flattened, it just now is going to take a very long time to really put it down if we're staying inside and social distancing.
I think so. I mean, the counter argument to that projection is China, but what China did was so fundamentally different from what we are doing.
Right.
They really enforced a complete societal shutdown where infected people were all placed in the same place, typically in a gymnasium, to convalesce together and get better together, and where the only reason you could leave your house was to go get groceries, and that was heavily regulated. And so, not surprisingly, that had a greater effect, whereas I'm assuming what I'm seeing in Seattle is the same in every city, that, when I look at the bus go by, it's a quarter full sometimes. And there are lots of essential workers who still need to go to their jobs. I think there's a very small subset of people who are not behaving responsibly, but frankly, I haven't seen a lot of that.
And do you think a small group of people like that can ruin the whole thing, or is it so small that it doesn't matter?
Ruin the whole thing is, I might not go that far, but the problem is that, and this is what's so fundamentally difficult about this for everybody, is that the actions of a few might propagate beyond. And you would never know. So my son and I were taking a walk. This is the one time I've seen something that really sort of upset me, but we were taking a walk by Lincoln Park, and there was clearly a house party going on in this apartment complex. And there were probably 40 people there. And I just thought to myself, if 2 of those people get infected and then they silently transmit it to a coworker, and that coworker visits their grandparent or whatever, that's really the outcome that we worry about. And it's so hard because you never see that effect, right? So these people who are at the party don't really understand what they're doing. But, I think anytime people break the rules in a way that is significant and really enhances the risk of infection, that possibility exists.
Okay, so I don't know what kind of projections you've seen, and this question gets asked a lot, but from your brain and seeing the projections that you have seen, if we continue to socially distance, I know this question comes up a lot, but how do you see it when do you see it slowly opening up? I know states and other countries are slowly opening up, but from what you can tell, when do you think it would be safe to start, opening up businesses again?
Yeah, I lost you for a second there, but I think you were asking about opening up when that will happen.
What would you, if you were in charge, when would you open?
Yeah, I think that the best analogy I've heard is that when we shut down, we turn the switch off, and when we turn on, it's more of a dimmer switch. Mm-hmm. So the question is not just when you open, but how you open, and effectively how you monitor once you've opened.
Okay.
The criteria I would like to see, and I'm not an epidemiologist, so I'm not going to give some number, but there are numbers being thrown around about the proportion of tests that come back positive should be very low. So rather than having, 10% of tests that are sent coming back positive, we would like to see that well below 1%, such that we know, and the negative tests are so valuable. And this is something that really needs to be embraced by policymakers and the public, is that the value of thousands and thousands of negative tests is so high, because it really it gives you a proportion, right? It gives you what percentage of people are infected who are seeking testing. So I would want to see a low proportion of tests. I would want to see a high availability of tests so that we can implement contact tracing very quickly when we detect new infected cases.
Are there a lot of tests around?
So I think it, unfortunately, depends on which state you live in, and it depends on the extent of the epidemic within that state. For people who are listening, there's a writer named Thomas Pueyo who's been posting on Medium, who has these beautiful graphs about different proportions of tests being sent in different states. And, the tests that are the states where they're detecting very low proportions of positive tend to be the states where they've not had significant outbreaks. So I think New Mexico comes to mind, where they're testing really liberally. They're not finding a lot of positives, and they're able to do so because they haven't maxed out in their testing capacity. Whereas New York and New Jersey hit a point where they did not have testing capacity to test anybody other than somebody who really might have it and really might be in harm's way. So they were really exclusively using their tests for people who showed up in emergency departments and for critical personnel, for healthcare providers.
And that's Thomas Pueyo. How do you spell Pueyo?
It's Pueyo. And he has written a series of 4 or 5 essays with beautiful graphics, which in my mind are really instructive. I mean, every time he publishes one, I learn. He's not a professional epidemiologist. I think he's a venture capitalist or something, but he's just really, really thoughtful and really presents the data extremely well. And so, the hope is that all of us become New Mexico, so that every state reaches a point where there are not a lot of circulating cases, and then we can have enough tests where we can really identify cases early. And the other key component is then having the infrastructure to perform contact tracing.
Right.
Where you identify different contacts of the people who are infected. And one of the interesting things I'm seeing in the literature, and this is well outside of my area of expertise, so I'm just sort of reading this with interest, is that there appears to be a debate brewing between sort of traditional public health practitioners who really feel like you need to do this the old-fashioned way and interview people and say, yeah, who did you come into contact with? Where did you go? and
Right.
track those people down. And what that requires is an army of public health workers and, thousands of people who are on the phone all day. I know this is starting to happen in certain states and cities. I've read about in San Francisco and in Massachusetts. But on the other end of the spectrum, and is sort of more tech-minded people who are talking about using cell phones as tools to really, in a more objective way, rather than relying on somebody's memory, tracking where somebody's been. So if I went to pick up dinner and I am diagnosed with COVID 3 days later, they can call the restaurant and say, hey, this guy, picked up his teriyaki at your place. You should be aware of symptoms. And if it's a prolonged contact, perhaps self-quarantine for a period of time. And I've noticed that these two camps are in some disagreement. My suspicion is that probably both are of extremely high value, and that they can really complement each other. And it's really interesting.
Is it possible for an individual to track their phone and everywhere they've been? For a person to do that?
No, I think you need software embedded within the phone for somebody else to be tracking the phone. Okay. And then you can imagine the privacy issues that go along with that. So it's not a simple issue.
But I mean, getting an army of people to talk to almost anybody who's had it is also a very difficult. I mean, it would take months, but I guess you have to start now.
And you have to be creative, right? You have to say, you have to break down some of the barriers that would ordinarily exist. So I think in normal circumstances, you would want that person to be a fully trained public health practitioner. But, maybe this is a good way to have college kids. Maybe it's a great summer job. It's sort of, with either approach, we need to be thinking outside of the box, and we need to be cross-pollinating expertise. Honestly, if there are a bunch of tech people who have never done epidemiology and who don't understand infectious diseases outbreaks, trying to come up with solutions in a vacuum, no way. Like that won't work. Right. But if they get the right people on board, and then I think there's really a great opportunity.
Now, do you think? I'm sure you've been asked this 1,000 times, but herd immunity in Sweden, obviously, you said 2 weeks ago, you were like, it's a very risky approach. And do you think with 2 weeks gone by, do you think that approach is working? Do you think it's irresponsible?
So the data that I've seen is that the death rate in Sweden is 10 times higher than that in neighboring countries.
Right.
So on the other hand, their hospitals have not been overrun. The situation within the hospitals is manageable. And I read an interview in the lay press with their national epidemiologist who's running this, who made the point that at least half of their deaths have been within skilled nursing facilities and group homes. And so that they consider that a failure, but had they been on top of that, they might be closer to the other Northern European countries.
Yeah. Tell that to the people in the nursing homes.
Right. Yeah. And so like at a personal level, I would rather have an elderly parent in Norway than Sweden right now. I mean, that's pretty clear, right?
Right.
But on the other hand, there's the side of me that's a little grateful they're trying, because it's not as if they've willy-nilly opened society. They're trying to push the envelope a little bit. And that's what all of us are going to be trying to do in the upcoming months. And the ability of a mathematical model to project what will happen is really, really, in my opinion, really difficult to do. When you're this analogy of the dimmer switch rather than the light switch, when you're making these fine manipulations and making very difficult decisions about opening schools or partially opening schools, or that, I think making predictions in that context is really hard. So what they're doing is providing valuable information. But from my perspective, it's somewhat alarming that their case rate is so much higher than their neighbors.
And are they, I guess they're willing to just to eat those numbers and go, okay, we failed that way, but now we've corrected, so it's actually, I believe they think it's working well. Is that true?
One of the more subtle points they make, which is I think a pretty good point, is that the way to measure this is not now, but at the very end. That if if the mortality catches up in the other countries, then maybe what they're doing is they're just allowing the virus. What they're sort of doing is like it's the equivalent of when they have these forest fires in national parks and they sort of let them burn within reason. That's what they're trying to do.
Okay.
And so the point I've heard made is that wait till the end to make comparisons about the death rate. But, that loses a little bit of steam in the fact that even, if the death rates end up even, you're still, the people who are dying in Sweden right now might have had a year extra to live without getting infected.
Right.
So just really, really complicated.
Yeah, when you say the end, when's that? What is Sweden saying when the end would be? When you can go, all right, see, look, we did it.
I mean, I can tell you what I think the end is. I don't know what to me, the end is when the COVID pandemic is no longer a global issue.
Right.
And we can look at every country, and I think every country will have a report card about how well they did.
Yeah.
And part of that, and I'm as I mentioned before, part of the report card is economic. So the mortality rate's clearly important. To me, by far the most important thing, and more specifically, deaths averted. So, which how many deaths did your country avoid by implementing whatever it is you implemented? But the economic measures are important too. So,
so do you think? I mean, with the way that our country, the states, it's up to the states, and some are opening and some are not. We're going to kind of inadvertently do a herd immunity? Will that it will just be our own kind of version of it?
I don't think we're anywhere close to herd immunity. I've seen no data at all to suggest that most parts of the country are anywhere near herd immunity. So I don't even think it's a relevant concept yet, to be honest. There may be pockets of New York City where there have been enough infected people where if there were a second wave, it would move a bit more slowly than it would otherwise, because it's important to note that many of those pockets, not surprisingly, are impoverished areas. People of color are now clearly more impacted in the major cities, and so it's not uniformly spread by any means within New York or Detroit or New Orleans. So, but that being said, I think overall we're nowhere near herd immunity, and I don't endorse the strategy of I don't think shooting for herd immunity is a viable strategy with anything other than a vaccine, really.
Yeah, so that is a good way to transition. So let's talk about, obviously there's been a lot of news in the last couple of days about a vaccine, and obviously Dr. Fauci was talking about it, and Remdesivir, which sounds like a character from Lord of the Rings and Gandalf's best friend. But can you talk about that? And there seems to be a great amount of positivity about it.
Yeah, sure. So Remdesivir is a treatment. It's not a vaccine.
Oh, excuse me. A treatment. Excuse me. A therapy. That's my best.
And I'm happy to talk about both of those things.
Yeah, let's talk about the therapy then, before the vaccine.
Sure. So the therapy, what you would want to achieve with a therapy is to decrease the probability that somebody would die of infection, and decrease the probability that they would suffer from infection. Maybe decrease, if you were to catch them early, decrease the probability that they would end up in the hospital. And maybe if you treat them early enough, stop them from shedding the virus and make them less likely to transmit to other people.
Right.
So the goal of the Remdesivir studies that have been done up to this point are merely to save lives, because they're capturing people who are already in the hospital, and not just in the hospital, but very sick. So people who are requiring oxygen and often have abnormalities on their chest x-ray. And the really important thing about the 2 remdesivir trials that came out yesterday were that they were the first studies that were randomized, meaning that if you entered the study, you essentially are randomly put into either a control arm where you're getting a placebo or the drug. Person giving the medicine doesn't know which one you're getting. You don't know which one you're getting. The 2 bags that would hang, like the placebo and the drug, look the exact same.
Mm-hmm.
And that becomes really important in terms of analyzing the data and removing any possible bias from that data. And both of these studies were relatively large as well. And one of them is still ongoing. So the first one in China, they really focused on very sick patients. And that one was actually published in a journal. And in that study, there was no statistically significant benefit. So the drug did not show a decrease in hospitalization or a decrease in the death rate. But it was underpowered, meaning that because China eliminated the epidemic so quickly, they were not able to enroll enough people in the study.
Oh, and I guess that's a good problem.
Kind of a good problem, yeah. And there was this trend that was intriguing in the data, that it looks like the early onset of symptoms. So a shorter period of time between when they felt sick and when they got the drug, it looked like they might have done better. But again, not enough people to tell. The other study was a study that was done across the globe at multiple sites. And I was sort of proud of this because some of my friends at the University of Washington were really very deeply enrolled in running this locally and seeing the participants and continue to be involved. And the data for that has not been published, but there was a press release because the interim analysis was very promising. What it showed was that people who were hospitalized for, on average, 4 days fewer if they got the drug relative to the placebo. And it was very close to being statistically significant, but not quite, that there was a 3 to 4% reduction in death in the people who got the drug, which is really, I think, a really fantastic result and promising. The caveats are that it was not statistically significant, so we really have to wait for the whole study to be analyzed to really know and to get a better feel for what the drug did and didn't accomplish. And the other caveat is that one way to look at a percent reduction in mortality is something called the intent to treat. And so if this turns out to be real, and there's about a 3% reduction in mortality in the people who got the drug, that means it takes about 30 people to treat to save one life. And there's a glass half empty and glass half full approach to looking at something like that. So the glass half empty is that if it's your family member, the chance that the drug is saving their life is actually pretty low. And the reason that's part of that's driven, it's not so much the drug, it's the fact that of all the people who got the drug, even in the placebo arm, the death rate was actually pretty low. I mean, I can't remember if it was 10 or 15%, but akin to what we've been seeing. But if you then multiply that reduction across the entire population of people who could get the drug, now you're talking big numbers. Now, you know, let's say you treat 100,000 people and you save 3% of those people. That's a lot of people, right? That's several thousand lives. And so, to me, it's a very encouraging result. As I mentioned last time, my particular passion with this and what I'm really trying to promote is getting people treated as an outpatient before they even get to the hospital. And my hope and my hypothesis, though, again, you would have to do a study to prove it, would be that you could increase that number well above 3% if you treated people before they were starting to get sick at all.
Right.
And there's this window where people are sitting at home for a week with symptoms before they get to the hospital. And that's what I hope when we next speak, and, if we continue to have these conversations in a couple of months, I hope I can report on studies that are starting to do that, because to me, that is one way we can get out of this, is even if we can't completely stop the spread of the virus, if we make it less frightening, if we make it less of a fatal virus, and we make it something that we can manage at home.
Yeah. And is remdesivir something that eventually you could possibly take at home? But because it sounds like it's pretty complicated. Obviously, you have to be. You don't really need it before, is it something you could take before you're very symptomatic in a hospital?
You could. So there are two issues with taking remdesivir at home. The first is that it's given as an IV.
Right.
And so one of the things Gilead, the company I know, is interested in is seeing if they could reformulate it as an inhaled version of the drug. And the other, as difficult as it would be to give somebody an IV drug at home, we do this with antibiotics, we do it with chemotherapy, and it would be far cheaper than having the person end up in the ICU. But it would be preferable if we had the choice between an IV drug and an oral drug to have the person take a pill at home. And so there are other drugs under study to accomplish that. The second issue, which I'm just kind of learning about, is it's easy to sort of sit on your sofa and say, why don't they make more drug? But the process of making a drug is incredibly complicated. And it turns out they get different components of the drug from all over the world.
It's like it's like you're like, I'm going to build a sailboat. So yeah, it takes
that's exactly right.
So now that if this is the drug because now I feel like everyone's focused on getting 1 million doses or 5 million doses, would take how long for something like this?
Yeah, I don't work for Gilead.
Right.
I've had conversations with people at companies like Gilead about this process. And even in the best of times, it can take months. And particularly, we haven't talked about vaccines yet, but for vaccines, you actually have to build entirely new factories to do it.
Right.
And so the process is not straightforward. And apparently the impact on the supply chain due to the pandemic has made everything more difficult, as with every other industry. So
you can barely get toilet paper. So, let alone complicated drugs that are through complicated delivery systems.
Exactly. So that I understand a lot less, but I think there will need to be some patience about getting the supply up to a point where.
But you are. Dr. Fauci said yesterday he was as optimistic as in the 80s when AZT came out for AIDS, because that was the beginning of the therapy. He was that confident or that positive. It sounds like you're the same way.
Yeah, I think AZT is a perfect analogy because, and I think actually remdesivir has a lot of promise, but there's a lot of uncertainty with it. And, AZT ended up disappearing within 4 or 5 years after it was invented because it was replaced by drugs that were better tolerated and more potent. Mm-hmm. So I have no idea how this will play out. It's possible that remdesivir, we'll learn that if we give it earlier, it is in fact extremely effective, and we'll figure out a way to deliver it to outpatients, and maybe we'll stop there. But I certainly don't think the search is over. Thankfully, hundreds of drugs are being screened, many of which are FDA licensed for other indications, like hydroxychloroquine, for example. That where and if we could identify a pill that had equal effectiveness, then I could envision a situation where folks in the hospital might get remdesivir and folks at home get the pill. But we'll see.
So then 2 weeks ago when we talked hydroxychloroquine, whatever, it sounds like a superhero or an evil superhero. That was the thing everyone was talking about, and that now I feel like it's not discussed at all. So where are we with that one?
I think we're in a better place. We're in a better place in the sense that there's skepticism about the drug. Far fewer people are taking the drug without being enrolled in a clinical trial. I mean, from my simple perspective, if we don't know if the drug works and
Right.
it's not the safest drug in the world, then really we should. And the more subtle thing is that the side effects associated with the drug are much more likely to manifest in people who are already really sick. So that some of the heart problems, and so I really like the fact that we're moving towards a situation where the majority of people who are getting the drug, I hope, are enrolled in a trial and a placebo-controlled trial, so we get an answer.
And yeah, I think you said 2 weeks ago that there was like 15 tests or trials going at once.
Yeah, that still bums me out. No change there. But I wish we had 15 trials looking at 7 drugs rather than 15 trials looking at one drug. But and what that speaks to is really for the next time. I do think that there needs to be an infrastructure where we are ready to go when this hits, and we're much more nimble about creating the capacity to screen drugs rapidly and be testing a wide variety of drugs early, and to be treating nobody willy-nilly. You shouldn't have a situation in a hospital where doctors are just making up decisions based on the 3 cases they've seen before and they're not really sure. A far better situation would be to be ready where, okay, we have a new pandemic where it's a dangerous virus and we have 10 drugs that work. Everybody we see is going to be in a trial. I mean, that's the rainbow with a pot of gold at the end of me for the next time. So that when we're 2 months in, we already know what we're doing. So we're making informed decisions a lot earlier.
Now, you also mentioned Kaletra 2 weeks ago. Is that still a therapy that's happening?
It is definitely not being used routinely. It's being tested now as an earlier therapy
Right.
in clinical trials. It failed as a later therapy, but I think it's still worth doing because again, that when people are really sick, one of the things that happens with the infection is that it becomes a little bit more of an immune disease than a viral disease, that the inflammation is what puts people in harm's way. And so if you're treating very late, it's possible that eliminating the virus from replicating might not stop this immune cascade, as the people often use, of inflammatory chemicals in the bloodstream that make people very sick very quickly. And so it's possible Kaletra could work if given early. I'm not sure there's a huge amount of optimism about it, but it's certainly worth having a look.
Okay. And what about this convalescent serum that where you take platelets or you take plasma from someone who's gotten over it and you put that into someone who's sick?
Yeah. So there's been a long history of that being an effective way to treat infections, and the data I've seen is pretty hopeful in that capacity, but it's not been in a controlled fashion at all. So that's being tested across the world, and there are now clinical trials looking at this, but again, without a control group, it's hard to know. The more modern version of that, which is exciting and I think carries great potential, is something called a neutralizing antibody infusion, where you essentially identify the antibody that counts. So rather than simply, so if you get somebody else's plasma, you might be getting a good dose of SARS-CoV-2 antibodies, but you're also getting all the other stuff and all the other antibodies that person has. And so a more focused approach would be to isolate the antibodies that have the ability to bind the virus and to prevent it from infecting a cell, and to then give those antibodies specifically. And that potential exists, and there are a lot of people I've spoken to who really feel like that's, in the medium and long term, our best hope. one of the cool things about that intervention is that you can engineer the antibodies to have a very long half-life in blood so that they stick around for a very long time. And so you could imagine, particularly, in a closed environment, so a Navy ship or an assisted living facility or a skilled nursing facility, where you could identify the index case and then give the antibody to everybody and protect them for the next 3 months. Or if you happen to catch them when they've just been infected, treat them. So that's a very promising approach, and it's a very hot area of research. But those trials are long and hard, and there really needs to be a very close eye on the safety of that approach, because it differs quite dramatically from the more typical approaches we've used with pills, which have much smaller molecules to target the drug.
Okay, so and it would, with the convalescent serum, it would also, it's not something that you can give to millions, from what I understand, or is it that it's much harder to get that into people, or get a huge amounts?
At the moment, yes. The neutralizing antibody situation, I'm not sure. My mentors remind me that there was a clinical trial, I think I might have mentioned this last time, for HIV prevention, where 4,000 people across the globe received an infusion of antibodies to prevent HIV infection.
Mm-hmm.
And this was done in clinics. And so I guess sometimes when history is happening, it's hard to use your imagination. It's hard to imagine for me clinics popping up all over the country and the world where people get infusions with antibodies and then go on their merry way. But that might be just simply be my lack of imagination.
Okay.
This is such a big deal, and we're so stuck economically that this type of outside of the box thinking is critical. And so maybe what seems like science fiction now will be the routine clinical, standard of care in a year or a year and a half.
I think you have a great imagination. Look at that lighting fixture.
Yeah.
Nobody has that.
I blew the glass myself. That was,
wow.
Yeah.
Hope you didn't get burned. But so now let's talk about a vaccine. And as I mistakenly said before we started talking about therapies, but there's just in the last couple of days very promising news about a vaccine. And can you talk about the study that came out of Oxford?
So all I've read about the Oxford vaccine is the press reports. I've not seen the primary paper, but it's becoming very clear that there are vaccines that generate the type of immune response you would want to see in a person that protects against the virus. And so that's really promising. There's also been a study from China where, and this was using a vaccine product that might not really be something you could, I'm not sure that it would meet the bar of what would be considered safe in a human study, but I'm not sure, where they essentially inactivated SARS-CoV-2 with a chemical, and then they injected that vaccine to monkeys and protected the monkeys from infection, which was the first time that this has been demonstrated with this virus. Like with a lot of early vaccine studies, they very much weighted their studies so that they would get the result they wanted. They vaccinated the monkeys 3 times. They challenged the monkeys with virus immediately a day after the 3rd vaccine, when they knew that antibody levels against the virus would be very high. And that's often the case with how these studies are done, because you want to really identify that, gosh, if we set this study up perfectly and it still doesn't work, then we need to drop this candidate. But it does, I think overall what it tells me is that there is a possibility to mimic the immune response that you would get with natural infection with a vaccine. And I think the Oxford study has shown this as well. So the next step is showing that this will actually protect people, and then for how long?
Yeah, and they're saying in the press releases, they're saying that could be by September. Do you think that's wildly optimistic, or I mean, having a vaccine by then, not necessarily having the zillion number of doses needed, but that's what they said.
I think, yeah, I think that's very optimistic. One of the really interesting conundrums we have is that the typical way to do a vaccine study would be to do a randomized placebo-controlled trial where you give half the people a placebo and half the people a vaccine, and then wait and see if they're protected against infection. Here, with a lot of the research that's been done, there's been a lot of chasing the virus around and not seeing enough cases. So if you were to do this vaccine study in a country that has successfully flattened the curve, you wouldn't generate enough infections in the placebo arm to really see if the vaccine has done anything. So one of the things that's being talked about, and this would be the quickest way to get there, is something called a human challenge study, where people willingly get infected with the virus under very controlled circumstances, and it's done so in a placebo-controlled fashion. And then those people are followed both medically and scientifically very, very closely after they get challenged with the virus to see what happens.
You got some brave people to do that.
Yeah, so I would agree. A lot of the arguments that are made about this approach are ethical arguments, and so the people who are lobbying for it make what they base their argument on is that they say, listen, lots of people take risks in life, and those risks might be occupational risks. So you have people who volunteer to be in the military, you have people who volunteer to be firefighters, you have people who volunteer to play in the National Football League. All of these things are inherently risky. You have people who do risky things, for fun. And so this is just an extension of that. And there's obviously a service component to humanity. The other argument that's made is that we've already been doing this for a long time. When I was getting started, I was part of studies as study clinician where we challenged people with malaria and tested different therapies and vaccines. In that case, it was, they were still getting malaria, but the second they became ill or positive for the infection, we would start to treat them. In this case, it's a little different with SARS-CoV-2 because if they became very sick, maybe now we could offer remdesivir, but still we don't have a perfect therapy, so there would not be a safety net. And so without question, people enrolling in a study like this would be taking some risk.
Yeah. Now, a lot of people are asking, I've just seen from the questions scrolling up, they're asking about blood clots. And can you talk about that for a sec?
Yeah, sure. So there's been a lot of attention about this in the lay press that after people get infected and appear to be doing better, or sometimes when they're in the thick of it, there appears to be a higher risk of developing blood clots of various varieties, both in arteries. And so the type of blood clots that form in arteries would cause heart attacks or strokes, but also in veins. And so the biggest risk there is something called a pulmonary embolism, where blood flow to the lungs gets obstructed. So this appears to be a real thing, but it, again, needs to be studied very carefully to really tease out the absolute risk of this as far as relative to other patients who are sick in the hospital, because these are things that happen with a greater frequency in critically ill hospitalized patients to begin with. I think the most compelling stories anecdotally are young people who don't get very sick with the virus initially and then show up with a stroke. I think the way I would frame this for the general public is that even if it's occurring, it's clearly not common. I mean, it's not the type of thing where if you get the infection, your risk of having a stroke in the next month or two is high enough that it's affecting the number of hospitalizations, for example. It's just so dramatic to see a 35-year-old show up with a stroke at the hospital.
Right.
That I think once that happens, everybody's antenna are up. So I suspect that the numbers are not huge, but that it's nevertheless something that needs to be tracked down.
And you're saying in hospitals anyway, blood clots in veins or strokes or heart attacks are just more common?
Absolutely, yeah.
Okay.
Particularly in veins, particularly the pulmonary embolism.
So it's hard to say whether it's the virus is causing those.
Yeah, and it probably even just a little bit more subtle is the degree of risk. So if it's, I think all of us, just as a physician, when you see a case that is tragic or unusual, it sticks with you.
Right.
And then you can become a little bit biased in terms of overweighing the risk based on the fact that, maybe you've formed an attachment with this person or their family members, and then something terrible happens and you remember it. But we need to try to disengage that part of our brains when looking at this and see, okay, what's the absolute risk that this is happening?
Yeah.
And it can't be huge. Otherwise, it would be affecting the hospital numbers. But
right.
I suspect it's there. So that's really the next step, is just assessing the total effect of the risk, really.
And we talked 2 weeks ago about how kids are way less affected by the virus, and which is such one that God, thank God.
Yeah.
Has there been anything that's come out as to why? I'm assuming it's continued, because you don't hear much about kids being infected unless they have compromised immune systems. Is there any new data as to why kids are seemingly okay or immune?
Yeah, I haven't seen anything in the last, I'm missing stuff. So the answer is probably, and I missed it, but there's nothing I've seen. There's the leading hypothesis that I'm aware of is a different density of the receptors that the virus uses to enter cells in kids.
Oh.
But I feel like there's certain things 5 years from now, we're still not going to have an answer, but I bet that we will understand the pediatric angle of this very well. It seems like a question that can be answered, but I have not seen anything new in the last 2 weeks.
And did you also read about this thing where one of the symptoms is your toes look like they're frostbite?
Yeah.
That just came out, and I don't know. Again, there's so much stuff coming out that is hard to answer. Have you heard about that?
I have. I didn't have. I just saw the picture, actually, and I can't even remember where I saw it. I don't know. I should look into it more closely. If for folks who are really critically ill in the ICU, having toes turn different colors is not uncommon because the blood vessels clamp down. But I don't know enough about it to answer it well, whether that's something that people who are kind of otherwise doing okay at home with mild symptoms get, or but so I don't know. It's certainly not enough to say, oh my gosh, your toes look funny, you have COVID. I can say that, but
of course, because most people's toes look pretty funny.
Yeah.
No. So, and then I asked you this 2 weeks ago again, and if there's anything that's changed, but I have a number of friends with cancer. My friend Kate has stage 4 liver cancer. 2 sister friends of ours have breast cancer, and obviously the complication, it is being treated for something that serious during a pandemic. Could you again speak to if you're in a situation like that, how, I don't know, terrified should you be, or should you be comforted that hospitals have in the last month really made it possible so you're as safe as possible while getting treated?
Yeah, I feel like that. I feel the same way, that the hospital in and of itself, and the clinic in and of itself, need not be a high risk environment relative to other places. I think that the same precautions that you would take as far as physical distancing apply. Very frequent hand washing. The only exception is these situations in emergency rooms that are completely overrun. And just seeing a video of some of these emergency rooms, both in Lombardy and I saw one in Queens, where it was horrifying, and you could tell the infection risk was high for anybody there. But I don't think that's the norm, and particularly for people who are getting their care in a controlled setting. And for we see a lot of patients in follow-up with infections from cancer, and we are finding that we need to see about 10% of these people in person. We're able to do most of our work through telemedicine. And it's sad. I mean, it sucks to not see people who you like face to face. But as far as whether it's affecting our plan of care, there are very few instances where it is. I feel like we can, it makes, I'm sort of an old school physician. Like, I like doing physical exams, and I like listening to people's hearts and all that stuff. But the fact is that in most cases, we can make a very good plan over the phone, looking face to face. So that's really been a little bit of a revolution, and I think that's going to carry forward when this is all over. People don't need to come in nearly as often as they are to get care for things like this.
Now, if you're my dad, my dad had reverse shoulder replacement surgery scheduled, which he obviously has postponed. When now I'm just speaking personally. When would you go get that done? When should I tell him to get? I mean, I know you're just, but is it time to start having those surgeries again?
I think it's time for him to call his surgeons. A lot of the surgeons I've met are really eager to do cases now. And I think the OR is, I can't speak to other places, but if you get a surgery at UW now, even if you're asymptomatic, you're screened as a patient for COVID.
Yeah.
So the pace at which routine elective surgeries open up is very dependent on the local epidemic. It's very dependent on the policies of a given hospital. But I think it's okay to ask now. I don't know. I don't have a right answer for your dad in particular, but I think it's definitely the time to just say, hey, because we're starting to see it open up a little bit locally, because physicians want to work, nurses want to work, and a lot of the routine stuff, if it can happen, should.
I'm jumping around here just a little bit, and I know I've kept you a long time, but
no problem.
There's been a lot of talk about reinfection and a person who gets a huge exposure, like maybe all those Italian doctors that very sadly passed away, they get a terrible case of it. Where is there any new information about A, reinfection, and B, the amount of exposure you get? Is there anything new or that is solidified?
I don't think there's much new information about reinfection. There's what has changed is there appears to be a greater appreciation of the fact that we have yet to demonstrate that having an antibody protects. So, and that appears to be gaining mainstream consideration. That's just my anecdotal experience that people are talking about this. But I don't think there has been data yet to really show the impact of reinfection and whether it's a real thing. And if so, how it happens. And there's a lot of people who are hypothesizing that maybe you can get reinfected, but the second time you're much more likely to be asymptomatic because you have some degree of protection. Mm-hmm. But I still think it's an untold story. The second thing is the idea of whether the exposure dictates the severity. I have not seen any new data that inform that story. I think we all have to run with the assumption that it probably does, but that's an extremely hard study to pull off, if not impossible in humans. Somebody might do it in a non-human primate model of infection.
Okay.
I'm not sure, but
Okay, so from what, I mean, I've had you on now for an hour, and people are saying that you look like Peyton Manning's smarter brother, so congrats, Peyton
Eli.
Manning.
So I look like Eli.
Yeah, well,
That's great.
Eli has more hair, again, Peyton has less. Thank God we won that Super Bowl. Go Seahawks. But, okay, so it kind of in conclusion, I'm going to wrap it up, but as of today, you are much more positive, it seems, than you were 2 weeks ago. Is it safe to say that? Not much more, but just there's more hope than there was?
Yeah, I think that from the epidemiology point of view, we've done our job, though, again, there's a lot of tragedy that is coming. That's
right.
Just the bottom line. Therapeutically, it's very good to know there's a drug that clearly has an effect. I think that we're all we're just thirsty for good news now. We're thirsty for hope, and that having news like that tells us that we might be in a situation where this becomes a more manageable thing in 6 months or a year. And the vaccine progress is really going as I would hope and expect. I can't imagine a vaccine being widely available in the fall. But nevertheless, I think that the progress is being made. And the other thing I'm starting to see is there was a piece in the Wall Street Journal of a group of scientists coalescing around the idea of a Manhattan Project for this virus. And that I really liked to see that. Part of that is breaking down some of the traditional, really helpful things that are really helpful in the normal world. So if you're trying to approve a blood pressure drug or a cancer drug, then you need to do so very carefully and methodically. But some of those same structures within the FDA might not be helpful. I think we're in a point where there needs to be a system where you can just get the idea to the clinic in a study as quickly as possible. And I had this vague sense of frustration that I couldn't quite articulate, but I was seeing the virus blow through communities, and as it was on its way out, studies were getting started. And what I'm starting to see now is an understanding of that and a recognition that we need to be extremely nimble and fast if we want to keep up from a research point of view to establish clinical best practices. And so that's been really optimistic as well.
That's great. And boy, I hate to bring this one up, but there's when I read it, it's taking place in the Seattle area, but a guy is selling through his lab a vaccine. This guy named Johnny Stein. I get worried about anybody named Johnny who's in their 50s. But if you could just quickly speak to when someone says, "Oh, I got a vaccine. It's $400. Come and get it." What do you think of that?
Yeah, I've had tough experience with Johnny's as well. I'm sure there are a lot of, but I didn't know. I haven't heard of Johnny Stein.
All right. Well, then it was in the Seattle Times yesterday, and so maybe it's. I think it's safe to say anybody who says, "Oh, I got the magic bullet, come and get it," it's probably not that thing. It would be great in some fantasy world, but my guess is that it is not the case.
Maybe the Seattle Times should leave that one alone. That's not helping.
Right. And you would obviously recommend people still socially distance, stay at home. If you got to go out, wear a mask, wear gloves, be really vigilant on that, and people hang in there because the alternative of going out is way worse.
Yeah, but all that is true, but also look after your mental health. Get outside.
Yeah.
Zoom with friends. Don't be despondent. Take this as an opportunity to improve in some way.
Yes.
I mean, all of these, it all sounds trite, but otherwise,
I just learned French. It's great.
Yeah, me too.
Yeah. Yeah, have you been paddleboarding?
Yeah, we've been out a couple of times.
Any more dirty looks, or are people kind of like, well,
Yeah,
okay,
I think it's the wetsuit. They're not liking the wetsuit, so.
okay,
Yeah, no, it's great. I think it's so important to live a little as much as you can, and because
yeah.
this is going to be a long haul. This is not going to be the next.
Right.
It doesn't end in summer, unfortunately.
I think my family and I are going to go for a cruise. Just a nice cruise to the Bahamas. Does that sound safe?
Yeah,
Also,
yeah.
well, doctor, I'd love to do this again in a couple of weeks and see where we are, because it changes all the time, and you are a steadfast voice of reason. And even if the data, or there's not a lot of information, the way you talk about it is very calming, and it's very clear. Way better than Ken Jeong, who just every time I talk to him, who's also a doctor, I'm more alarmed than ever, especially because of his consumption of Coke Zero. But if you want to do this in a couple of weeks, I'd love to do it.
It would be my pleasure. This is so fun.
Great, and I look forward to a new room in your home, and some sort of light fixture, some sort of new light fixture.
Yeah, you bet.
Cool. Well, thank you, doctor. Ladies and gentlemen, Dr. Joshua Schiffer. Go to fredhutch.org/McHale. That's fredhutch.org/McHale, and you can see this whole thing back again. You can see some of the cabinets in my home, some of the beautiful blown glass the doctor did last week, and if you want to watch this whole thing again. So that's fredhutch.org/McHale, and thank you, Dr. Joshua Schiffer, for doing this and taking time out of your day and neglecting precious research to talk to some dork in Los Angeles. So thank you.
All right. Be well. Be safe.
All right. Thanks, doctor.
Bye.
All right. Bye, everybody. Thanks for tuning in.